Good morning, everybody. Sorry for the small delay, but it's really excited that Dr. Muller Rossouw is here today. And just his bio, he studied medicine in the University of Stellenbosch, and he did a postgraduate diploma in HIV management and mental health at the College of Medicine, South Africa. He's completed his MMed at University of Pretoria, and there he specialized in pathology chemistry in 2022. Currently, he's a consultant in chemical pathology at ampath, and he's working in the Specialized Chemistry Department. He's got a professional interest in occupational biomonitoring, as well as industrial and clinical toxicology and porphyria. So today, it's really excited to announce Dr. Muller, and he's presenting Porphyria Unmasked, the clinical chemistry behind the crisis. Okay, Muller, you can go ahead. Thanks.
Thank you very much, Michelle. Good morning, everybody. I hope there's no echo and that everybody can see everything so that we can get going. So thank you very much for tuning in and for listening and for joining today. So I am working at the previously known esoteric department, and immediately the word esoteric needs to tell you that there's some weird and wonderful things happening in our laboratory. So and we do a lot of these porphyria testing. So ampath offers a completely comprehensive porphyria testing service. We are one of the few laboratories, if not the only laboratory, that does fractionation of porphyrins on all the matrices, blood, stool, and urine. And then we ultimately report on your porphyria results, and we give you a diagnosis, or try to give you a diagnosis. All right. So let's start this off with an interesting little snippet from history. So King George III, who was around in the late 1700s to the early 1800s, and he was a very interesting guy. He captured, his behavior captured the imagination of authors and historians and poets through all out the world. And let's look at why he was such an interesting person. It was not for his strong leadership style, but a lot of different and other types of health issues that captured everybody's imagination. So he presented, or he had psychiatric symptoms. So very important for you to note that the psychiatric symptoms were not reported by a qualified psychiatrist at this stage. It was gathered from histories and things over the years. So obviously some of the taglines that were given here, it wasn't noted like that in his doctor's files in the 1700s. So he had he described, or people described him as having hallucinations, and he was acting paranoid, and he would talk for incessantly for hours and using complex and disorganized speech. So if we just look at that little paragraph, I mean, this can be a lot of things. I don't immediately jump to porphyria when I see this type of presentation. He also had distinctly described manic behaviors, being hyperactive with pressured speech and inappropriate laughing at times. Then between these distinct described attacks, he had depression and anxiety, and he also struggled to sleep, being quite agitated between these distinct acute attacks. All right, so those were the psychiatric symptoms. And if somebody had to press me for an answer based on that, I would probably not put porphyria as one of my differentials and maybe lean towards the psychiatric side of things. But the difference with him is he had these very distinct physical signs and symptoms. Yet again, we're basing this little summary on historical data, and this was by means of writers just summarizing their king's strange behavior. So he had these distinct episodes of severe abdominal pain associated with constipation, muscle weakness, progressing to full-blown paralysis at times. He had tachycardia and hypertension, so sort of an autonomic dysfunction, and then peripheral neuropathy. He was also tend to shy away from light because his skin apparently blistered quite regularly if he was exposed to sunlight. Then he had this dark reddish urine, the purple urine, which I think is something that most medical students will know about porphyria. Their urine is a different color, and especially when it's exposed to light. And then, therefore, there was this term, the royal purple disease. So it sounds quite imaginative and interesting, but it's a lot more than just your urine discoloration. And then, unfortunately, King George will always be known as the king who lost America and his mind. So then when we go further in the after shadow or the aftermath of Halloween, I thought it was important for us just to explore the link between porphyria and vampirism. So we do know that people like to be the humans are creative and they like to make associations and very imaginative. So the porphyria picture captured the imagination of a lot of historians, and they say that, or the historians and medical historians, they suggested that the porphyria attacks contributed to the folklore descriptions of Dracula and vampires, and we'll look at why that is. So specifically the cutaneous porphyria, because it led to some destruction and physical changes, and it might resemble the take on a vampire. And then the association is obviously purely speculative because vampires don't exist. So I am just going to talk about those elements that stood out from the vampire folklore and how it comes back to an actual porphyria case. So vampires avoid light. They want to stay. They only come out at nighttime. They've got blood-stained teeth from drinking blood. Their urine can also look like blood, and they are screaming, angry, having fits, which we know that in the olden days just was you are possessed. So if we take that back to medicine, the features that were highlighted in this fictional descriptions actually are relates to porphyria, purely because these patients are photosensitive, so they stay away from the sunlight. Blood-stained teeth, erythrodontia, where the porphyrin rings will actually deposit in your dentine, and you can have red or very dark urine. That's the urine like blood. And then the screaming and the fits is because they are in extreme pain. So no, they are not vampires. They are purely having a crisis. So there's just an example of the erythrodontia. All right, so at the end of this session, I'm going to briefly be touching on the pathophysiological principles, just because I don't think to dwell on them is of clinical relevance for the clinician that needs to investigate and exclude a porphyria attack in their patient. So we'll be touching on some clinical presentations, then very important mimickers, pseudoporphyrias, how do we diagnose porphyria, and how can you easily test for your porphyria in terms of chemistry and genetic testing. So porphyria is a fairly common condition in South Africa, and there's a very good reason for that. We'll touch on that a little bit later. And porphyria refers to an umbrella term for a group of several related disorders. So porphyria isn't a diagnosis, it's an umbrella term. And then when there's subdivisions of what type of porphyria it is. And it's important to make that distinction. So they are usually inherited, autosomal dominant, recessive, and X-linked. The presentations may vary, meaning that these patients can present to basically any medical specialty, neurologist, psychiatrist, dermatologist, internal medicine, and the casualty departments. So because it can range from skin problems, abdominal pain, and delirium. So there are four main types of porphyria in South Africa, and in our diagnostic unit, these are the ones that we see. So we've got VP, the variegate porphyria or porphyria variegata, AIP, which is acute intermittent porphyria, and those are the really dangerous ones that you don't want to miss. PCT and EPP, more insidious onset, and they're usually in an outpatient clinic and not in the emergency units. But porphyria cutanea tarda, PCT, and then EPP, erythropoietic protoporphyria. So South Africa has the highest incidence of VP in the world. The pathophysiology, and I think the best way to describe the pathophysiology is if we think about the pathway in which where the core problem of porphyria lies. It seems it's like a traffic light that's not working. So I'll come back to that analogy. So the reason for porphyria is an enzyme deficiency. So I'm going to equate an enzyme deficiency to a traffic light that's not working. So an enzyme deficiency in specifically the heme synthetic pathway. The position of this traffic light or this enzyme that's deficient determines the pattern and thus the symptoms and the type of porphyria that you are going to see. So this pathway, the heme synthetic pathway, is the basis for all our diagnostic tests. And the accumulation pattern, so the cars that are accumulating because this traffic light is out, that will cause the symptoms that we ultimately investigate and then look at the different types of intermediates that are accumulating. So this is the porphyria pathway. And I'm not going to go through this. I'm not going to dwell on this. I just want you to understand that an enzyme is considered, or the enzyme is the traffic light, and then the little substrate or the cars or the intermediate prior to the traffic jam. Those are the culprits that we're going to be looking for. And based on that accumulation, you will then get a diagnosis like the ones that's highlighted in the disease column. Right, so I spoke about the heme synthetic pathway. So hemoglobin, globin, big protein. Heme is the functional component of that, essential for binding to oxygen. So you can see here the little iron ring in the middle of the little iron sitting in the middle of the porphyrin ring is so important to bind to oxygen, releasing oxygen. So the heme synthetic pathway is responsible to build that little yellow block. If you look at the red on the right, that is a complete hemoglobin molecule with those 4 heme groups stuck to it. And the porphyria pathway, the heme pathway, is responsible to make that little functional heme group. So heme is a protoporphyrin, which refers to the ring, and then it binds to iron in the middle of that ring. And that whole process is a tightly regulated enzymatic process where you get these buildups and blocks. All right, so I'm going to go through this very quickly because I don't think it's of any clinical relevance to a clinician. Obviously, the chemical pathology team that's zoomed in, you guys really need to know this. But I'm just going to touch on this to illustrate the complexity of it. So the heme synthetic pathway is an interplay between the mitochondria and the cytoplasm, and the whole process is dependent on a heme molecule. So in the absence of that molecule, the negative feedback of that molecule, if there isn't heme, this pathway is activated to make heme again, so that this pathway can then be happy and stop. So the whole process is dependent on that heme molecule. And that is important because that is your therapeutic intervention for the acute porphyria attack. You need to stop this pathway from happening because the cars that are accumulating before the traffic jam, before the traffic lights being out, those are the ones that are causing your patient to be in extreme discomfort. Right, so important to just note that this heme molecule, I'm not sure if you are seeing my pointer, I don't know, but let's see, oh, there's a laser. So just this heme molecule, this is very important for this whole pathway to stop from happening. And a lot of the precipitations is related to this heme molecule not being there, affecting this whole pathway to be in full swing. And then if there is an enzyme block, you get the accumulation of the substrates. Yeah. Okay, so important, we now spoke about the traffic lights being out, and that's because of a genetic predisposition or an issue with your enzyme that's not working as it should. It's either absent or it is not performing as it has to. But there are other reasons for the porphyria symptoms accumulating. And one of them, me having an interest in the occupational side of things, and I think the clinicians also need to be aware of that, are industrial exposures. So lead can also block your the enzyme pathway. Mercury is also responsible to block the pathway at certain points, and then arsenic is also a culprit. So lead, arsenic, and mercury, it can also contribute to your patient presenting with porphyria type symptoms. All right, so there are 8 very important enzymes. I'm not going to go through this in the interest of time, but I think this recording should be available, so you should be able to go through this at your own time. So these are the 8 extremely important enzymes that need to be functioning at optimal level, the traffic lights, if you may, and if any of them are off, there's an immense buildup of the precursors pooling into all the other roads, and now there's traffic on Witch Hazel, for example. All right, so the 8 enzymes are super important. Then if there are problems with any of these 8 enzymes, you get the porphyrias. So I've chosen this twilight picture because I'm going to talk about 3 of the most important porphyrias, and they are quite celebrities because they are rare and they are very interesting. Right, so an acute porphyria attack, or acute porphyrias, it's important to make the distinction between an acute porphyria, this is life-threatening, and a cutaneous porphyria, which is not life-threatening. So the acute porphyrias are the ADP, so this is the ALA dehydratase porphyria. I'm not going to speak about that because it's extremely rare. Then AIP, acute intermittent porphyria, which is because of a defect in the PBG deaminase, or dehydratase, sorry. HCP, which is the CPOX enzyme deficiency, so hereditary coproporphyria, and then VP, which is the porphyria variegata, which is because of an enzyme defect or a traffic light that's out at PPOX. All right, so how does an acute porphyria present? And I think this is important for people working in the casualty setting. So it's life-threatening. It's more common in women, and most frequently AIP and VP. Although there are others, but VP, just because it's such a South African porphyria, AIP internationally is more prominent. So there's usually a precipitating event, and then drugs can also precipitate an acute event. So important, a drug history, and if somebody is diagnosed with porphyria, to take note of the medications that they have to avoid. So barbiturates, anticonvulsants, oral contraceptives, and sulfonamides. And then a catabolic stress event. So if there's a prolonged stress or a very stressful situation, whether it being dehydration, people that are fasting, or an infection, all of that can be an acute event that might trigger a porphyria attack. And then alcohol binge, a lot of associations between a porphyria attack and alcohol binge. And then menstrual cycle. And you can think about why that is. If there is hemoglobin loss during the menses, that triggers that pathway to be activated. And if you have a deficiency of any of those enzymes or traffic lights, you are going to experience symptoms. So these patients present with severe abdominal pain, and that usually the casualty officer sends them to surgery because they've got a surgical abdomen. They can have gastrointestinal disturbances, constipation, they can be delirious, they can have psychiatric symptoms, anxious and psychotic. They have evidence of autonomic instability, hypertension, tachycardia, and then some other chemical disturbances include a biochemical picture suggesting dehydration, then hyponatremia, and this is said to be because of the syndrome of inappropriate ADH secretion, and then hypokalemia and hypomagnesemia. So the reason why these patients are experiencing these symptoms is because some of the substrates that are extremely neurotoxic is ALA and PBG. And if they accumulate, this causes they are neurotoxins, and it causes activation of the pain nerves. So these patients are experiencing pain, but you cannot find any reason for it because of these molecules that are damaging their nerves, causing this pain syndrome. Right, so let's go into Porphyria variegata. So one of the Porphyrias. So we have a founder effect in South Africa that basically means that a mutation has been amplified due to a genetic bottleneck. And I have a little picture and we can argue and debate on why there was a genetic bottleneck in South Africa, but it just means that there was a lack of genetic diversity, and this mutation wasn't diluted out, it was concentrated. So this is a South African genetic porphyria, and it is traced back to a family. I think it's the Jacobs family that came from overseas, and they then this mutation was amplified in the Afrikaner population, especially during the Groot Trek, where there was just limited amount of genetics, and it concentrated that mutation. It's autosomal dominant, so it gets inherited quite aggressively by the family members. I think it's 50%. And then this is because the traffic light that's out, or the enzyme that's defective, is the protoporphyrinogen oxidase enzyme. The clinical features, and this is unique to Porphyria variegata, they've got skin problems and they have acute attacks. So this is just a picture to illustrate the bottleneck. So you can see a lot of diverse genetics, but because of a bottleneck event, migration, or a concentrated genetic pool, you now get this mutation that's more prevalent in a subset of people. And keep on being transmitted or passed on to the following generations. Right, so how do we diagnose an acute Porphyria variegata? So history is very important. There needs to be a history of acute and cutaneous manifestations. It doesn't have to be there, but it really helps if you have a nice history. A family history, there's usually a family history of a mom or an aunt or somebody that has this, that has been diagnosed, or similar symptoms. Then in the urine, we find that the PBG is increased and the total free porphyrins are also increased. And this is found during the porphyria screen. This is the biochemical part that we will look at to decide if this is an acute attack or not. It's the PBG substrate that's accumulating, and that then also the free porphyrins will also be accumulating in the urine. Coproporphyrins are increased. And then, very important, in the feces, you also see coproporphyrins and protoporphyrins. Then the plasma fluorescence, there's an emission peak. So when we do the plasma fluorescence, we will see a peak at 624 to 628 nanometers. And that's something that we will report on in your report that you get, that you've requested from us. Then very important is the genetic screen. So obviously the genetic screen is not a replacement for the acute screening process. This is something that I would recommend to test for in the outpatient setting once the patient is out of their crisis, to then ask them to come in and to do the PCR screen for it. And we specifically look for the R59W mutation, or arginine, and W is tryptophan. So there's the mutation that they look for in genetics. But Nicole will tell us all about this a little bit later. Right. And then just the pictures, you can see the blistering on the hands, on the sun-exposed areas. So I've just now highlighted here, just to bring it back to the pathway. So you can see the yellow ring is where the enzyme deficiency, so this is where the traffic jam is happening by the protoporphyrinogen oxidase. But let's go on then to this part of the pathway where AIP, where the deficiency is with the HMB, so the hydroxymethylbilane synthase deficiency is the defective traffic light. So acute intermittent porphyria, I've included this picture because it's extremely painful. And this is seen more in the Nordic countries with with a Swedish genetic porphyria. It's also called pyroloporphyria. And this is more prevalent in the Black South African populations. It's because of an autosomal dominant mutation in the hydroxymethylbilane synthase gene. And this enzyme has a different name. It's also called PBG deaminase because this enzyme works on PBG. And if it's deficient, PBG accumulates. And they've got very high levels of PBG when you do the quantification of the PBG. So there can be a partial enzyme. There can also be partial enzyme activity that's impaired. And then the porphyrins themselves do not accumulate. So they can have sometimes the only finding that we see is just this very high PBG and not some of the porphyrins later on in the pathway accumulating because it's so high up in the porphyrin pathway. Then there's the induction of the ALAS1 mutation synthase, and then this is obviously also the target for when we look at when we do the genetic screening. So ALA, we're not testing for that in South Africa, but we do test for PBG, and the assumption is that they should correlate with one another, and these are the substrates that are accumulating in this specific porphyria and what we need to test for. So 95% of these patients have severe abdominal pain. They can also have psychiatric symptoms. They can have peripheral neuropathies, and they can also have urine retention and dysuria. And there's usually a nice precipitation for it. So barbiturates, the oral contraceptives, and sulfa drugs. The non-specific laboratory findings that could aid in your diagnosis is hyponatremia, and this can be due to the SIADH, and sometimes because of GIT loss, the vomiting, and renal loss of sodium, hypomagnesemia, and hypercalcemia, because these patients become relatively acidotic. So then they can also have this persistent background elevated ALT and AST, the transaminases, and they're also associated with mild elevations of pancreatic enzymes, the amylase and the lipase. This is more in the acute setting where you will find these other findings in an acute porphyria attack. So during the acute attack, the urine PBG will be increased. So you don't need to, in casualty, you don't need an absolute value of the PBG, you just need the screen. So what helps is if you just write there, query acute porphyria attack on your form and cover your urine with foil and send it to the laboratory as soon as possible so that they can do just a color reaction to say, yes, PBG positive, PBG negative. The urine uroporphyrins are also increased, but that you will only know once we've done the fractionation, and that can take up to a week. There's a plasma fluorescent peak, which is completely different to VP. So when they look at your plasma with this fluorescence, there will be a peak at 615 to 620, but this is more for the laboratory staff. And very important, AIP does not have any skin involvement. So it will really help if you write on your form skin lesions, no skin lesions. So the role of genetic testing. So because there's no clear-cut porphyria where you will always see exactly the same metabolites, it's more of a this fits in best with this porphyria. So you will very rarely you do see beautiful porphyrias where all the metabolites are exactly textbook, but then you do see some that doesn't really fit in with this one, doesn't really fit in with this one, and that leads to the indeterminate comment that we unfortunately sometimes have to put in your report, meaning that we can't really say, but it looks like PCT, it looks like VP. So this is why genetic testing helps us a lot, because just looking at the person's DNA will help us to conclusively say this is VP, this is AIP, etc. So we offer PCR testing specifically for variegata porphyria, and then next-gen sequencing, NGS, to look for the other porphyrias. So the expanded porphyria panel takes about 6 weeks. You just need to send in an EDTA, an EDTA tube, and this is the porphyria. NGS is the mnemonic, and those are the mutations that we look for. So basically everything. And this is ideal for somebody coming to the clinic with a history, or your outpatient department with a history of my mother has porphyria, I don't know what it is, then to do the genetics on it. And then the porphyria variegata, the turnaround time is a lot quicker, and it's just, it takes about 2 weeks for us to give you the mutation is present and the mutation isn't present. So they only look for the 59W mutation in the PPOX gene. That's all they look for. Okay, so what are the differentials for an acute porphyria attack? The list is extremely long. I'm not going to go through it, but I need you to understand that porphyria might seem like a nice, interesting diagnosis to write on the form, but there are so many other things that it could be. And to miss one of these things is just as bad as missing an acute porphyria attack. So all the reasons for having an acute abdomen can be a differential for your acute porphyria attack. Then autonomic neuropathies, hypertensive crisis, tachyarrhythmias, adrenal crisis, fibromyalgia, neuropsychiatric issues. Dr. Tabans spoke about the Guillain-Barré, so also one of the presentations of porphyria, an acute psychotic attack, delirium, a panic attack. So the differential is very, very big. And then lead poisoning, which is something that we often see more than we should in a modern society. But lead, if there is an association with an anemia, to consider lead as a possible precipitant or a cause for the porphyria attack. Then we're going to go through so now we've spoken about the acute porphyrias, AIP and VP. Let's quickly touch on the cutaneous porphyrias. So they are non-life-threatening, but they do lead to quite deformities, and this can really impact the patient's quality of life. So here I'm going to be focused on PCT. So we see a lot of PCT investigation requests from the dermatologist because it is so disfiguring. So the PCT, Porphyria cutanea tarda, and it's because of a defect of the UROD enzyme. And then we also see HEP, so that's the hepatoerythropoietic porphyria. And this is another one of those porphyrias where you can have skin lesions and acute symptoms, but this is not very common in South Africa, but they also affect the UROD enzyme. So they can have very similar presentations to PCT initially, but they also have acute symptoms. So a very difficult diagnosis to make in the absence of genetics. So Porphyria cutanea tarda, you can see the skin lesions look very similar to VP. And also affecting the sun-exposed areas, and it's because of a deficiency of the uroporphyrinogen 3 decarboxylase enzyme, or UROD enzyme. So, and this should be differentiated from other porphyrias. Obviously, you don't want to treat a PCT with hemarginate, which is an expensive emergency medication, if it's a PCT, because it's not going to help. PCT is non-fatal, but the patients mostly present with blisters and that are painful and a history of photosensitivity. Then, very important is PCT is associated with hepatic cirrhosis. So liver cirrhosis is an association, and these patients, so their liver functions also need to be monitored, as well as their iron functions, because there is an association with hemochromatosis. So I've just included some of the triggering factors for a PCT attack. Patients saying it gets worse, it's not as bad, it gets worse. So alcohol, massive factor, and obviously the alcohol can cause the skin symptoms and also affect your liver. This does not mean that it is a mixed porphyria. These are two different sort of porphyric pictures. The liver cirrhosis is independent of the PCT, but there is an association, obviously. Then hepatitis C, estrogen supplementation, HIV infection, hemochromatosis, and smoking. How do we evaluate a patient for Porphyria cutanea tarda, PCT? So the PBG needs to be negative because the enzyme block is the traffic jam is so low down on that pathway that we're not going to see the accumulation of ALA and PBG. So the PBG screen is negative. The urine porphyrins are usually very increased, and this is usually a sign that something is going on in the porphyria pathway if this urine total porphyria screen is positive. So the uroporphyrins is a metabolite lower down in the pathway that accumulates because of that UROD enzyme being absent. You see the accumulation of the uroporphyrins. Then the urine heptaporphyrins are increased and the fecal heptaporphyrins are increased. So that's why it's so important for you to also ask the patient to send in stool. I know patients don't like doing that, but it really, really helps the pathologist looking at your results if we do have that fractions in the stool. So fecal isocoproporphyrins are present in the stool, and this helps us a lot. When we see that, we are almost 100% sure that this is a PCT case. So please remember, if you are worried about PCT, to ask the patient to send stool to the lab. Okay, then I'm including this little picture because I've seen this. I remember as a child, I saw these pictures of the extremely disfigured children in the huisgenoot, and it was always so it made me it's quite an quite visual, and these patients with, you can see the little picture at the bottom, the erosion of the cartilage of the nose, for example, and this is because of the erythropoietic protoporphyria. Obviously, there are differentials for this, like scleroderma, but this is because EPP, erythropoietic protoporphyria, is because of the ferrochelatase enzyme defect. So at the very bottom of this pathway, you have the porphyria ring, and you want the ferrous, the iron, to go and bind in the middle of that heme molecule so that you can carry oxygen with your hemoglobin. The problem is the enzyme that's responsible for placing that little iron in the middle of the heme isn't present. So your hemoglobin is not effectively working, and you get accumulation of all the different substrates wreaking havoc on your poor body. So the enzyme that now accumulates because of the absence of the ferrochelatase enzyme is the protoporphyrin 9, or the PPIX. So this now accumulates in your body because there isn't that enzyme to take it through down into making hemoglobin, heme. So this accumulates in your liver, and it causes a non-blistering skin lesion. So these patients just have aggressive scarring, but not actually that classic blistering that you would associate with PBG and ALA accumulation. So this usually presents in children, and even as a baby, excessive crying and being very uncomfortable in bright sunlight. So the accumulation of the PPIX in the liver causes this protoporphyric hepatopathy, and then can also progress to cirrhosis. The main difference between this and PCT, obviously, two different enzymes affected, but there's no blisters, and they're also associated with gallstones. So you can see here on the skin of these two illustrations, the repeated phototoxic reactions leads to thickening of the skin, and the skin gets this scarring appearance that looks like a wax-like figure. So please be aware of the porphyria mimickers. So we have this entity called pseudoporphyria. So a bullous photodermatosis. These patients can also have this, obviously a big differential for bullous skin diseases. Then scleroderma can also sometimes look like the EPP, but obviously they don't have problems with their porphyria metabolism. So you'll probably get a study back that is completely normal, and that just means you need to explore another avenue. Some medications have also been associated with that can mimic porphyria type of picture and also trigger an actual porphyria. So the combined oral contraceptives, NSAIDs, and chloroquine, as well as patients with chronic renal failure, can also present with a porphyria type picture, and hemodialysis patients and then tanning beds can also precipitate and sometimes look like a porphyria attack, but obviously it's not porphyria. Then I've just included for the chemical pathology people online. So lead intoxication has a distinct biochemical picture that will guide you towards lead, lead being the culprit for the porphyria attack. So the delta ALA in urine, which we unfortunately cannot test, coproporphyrinuria, and then accumulation of free and zinc protoporphyrin in the red blood cells. So you will see on your fluorescence and on your red blood cell porphyria screen, you will see these peaks. Okay, so now just to take everything together, I've spoken a lot and maybe it's too chemistry heavy, but this is for the clinician. So at the end, the whole table will come together and this is this is what you must remember. So there are 5 scenarios in which I would recommend as a chemical pathologist, I would recommend you to test for porphyria. So number 1, a crisis presentation. This is usually in the emergency department. Scenario 2, investigating suspicious cyclical symptoms, symptoms that come and go, that sort of fit the porphyria presentation. Scenario 3, the dermatology clinic or the outpatient clinic or the GP clinic. Photosensitivity and blistering, I think it's important to investigate in that situation. Scenario number 4, a patient has a family history of porphyria. And then scenario number 5, a known porphyria patient now presenting with acute symptoms. So how do we address each of these different situations? So scenario 1, an emergency scenario. You need to do a porphyria urine screen, not study, a screen on urine that needs to be protected from light. Scenario 2, investigating of a suspicious clinical or cyclical symptom. You need to do a porphyria study. You need to submit 3 specimens taken at the same time, urine, stool, and an EDTA purple top. Scenario number 3, the dermatology clinic, blistering and photosensitivity. You need to do a porphyria screen, 3 specimens, urine, stool, and EDTA. And all you write on the form is porphyria study. Scenario number 4, patient has a family history of porphyria. Here I would suggest, in the absence of symptoms, here I would suggest to do genetics. If there's a history of VP or variegate or anything along those lines, I would go directly for the porphyrin VP PCR, so that we just look for that mutation. It's obviously a lot cheaper and the turnaround time is a lot sooner or quicker. And then if it's a family history that's not quite clear, then I would suggest to do the NGS, the next generation sequencing. And all you need to do is an EDTA tube. Scenario number 5, and we have a few chronic patients in the Gauteng area that will come in. They're known with porphyria, but now they're presenting to casualty with symptoms. So they obviously need the emergency treatment, which I will touch on just now. I know my time is running out, but in that situation, if it is a known acute porphyria, an AIP patient or a VP patient, to do the PBG quantitative on urine. Extremely important. This is the most important part, I think, of the whole talk. All your specimens, the stool, the urine, and the blood need to be wrapped in foil. It needs to be protected against light because the porphyria molecules degenerate when there's sunlight. Then please, and this is a favor, one medical professional to another, if there are skin symptoms, if you could please write on your form or phone the doctor on call or anything, or email just to write skin lesions present or skin lesions not, or family history or not. That's if you remember, because it really helps us when we interpret your porphyria fractions. All right, so why do we need to know what type of porphyria the patient has? Can't we just go ahead with the umbrella term, say you've got porphyria, that's it? No, the reason why we want you as a clinician caring for these patients to know what type of porphyria it is, so that number 1, emergency care isn't delayed, that arginate or heme arginate therapy can be initiated rapidly. And to prevent sending this already unstable critical patient to surgery, to prevent that is very, very important. So the patient needs to be educated on this condition. So when we know what is wrong with this person in terms of their porphyria pathways, we can avoid the triggers and the patient can be optimally educated. To manage associated complications like the liver cirrhosis and to counsel on smoking and alcohol and prevent Hep C infections, etc. Okay, we need to prevent Hep C infections anyway, but just to manage the complications. Then family planning and genetic testing. I know this is a very contentious topic, but to be aware that there is a risk of transmitting this to your descendants, this mutation, if you do have a mutation. Then also to get these patients into studies and to put them on the register so that when new medication become available, that you have these patients that can qualify for these studies. So there are a lot of new medications and therapies that can prevent an acute porphyria attack. So givosiran is one of them that can prevent that acute attack from happening. So that is, it's not 8 o'clock yet, but thank you very much for listening. And if you would like to share any of your personal experience with porphyria, that would be great. So that, yeah, I think the more we talk about porphyria, the more the information amongst clinicians, the less deaths we'll see and adverse effects. So thank you very much for listening. I appreciate it. Thanks.
Thank you so much for the dynamic, energetic, passionate presentation. That's quite amazing, you know, because porphyria has been one of the topics that actually, when you study for internal medicine, you just want to skip it. The reason that because of the terms and also understanding it is, you know, the enzymes, remember all of them, you just get bored. You don't want to do it. And it's only when you come to private practice, then you find out actually it's very important because you get stuck with those patients. And the truth about medicine that you only diagnose what you know. If you don't know it, you don't think about it. And that's, I think, that's what really highlighted about your presentation very well. So I just got two questions. One of them already perhaps answered it. One of them that we have always associated porphyria, certain porphyrias with the surnames. And you mentioned Jacob is one of them. And then I think there are names that I think actually that you could actually link them to it. So I don't know whether you know quite a few them because that's quite helpful.
Yeah.
And then the second thing, of course, is that should we be screening other psychiatric patients? That's, I mean, Cornell always say that once the moon start having a full moon, so that means the problem comes in. Is there an association with that? What happened with the moon is in summer? Does that mean the risk increases? Thank you.
Yeah, so I know that that one of the surnames is also van Rooyen, is also a surname, a family line that is associated with porphyrias. Van Rooyen is another one, and I can't remember. I think there's one more family, but it's Afrikaner surname. So I know van Rooyen family also carries, unfortunately, that line of porphyrias. And then in terms of this, yes.
Not Engelbrecht.
Engelbrecht, I'm not aware of Engelbrecht. Possibly, I don't know.
But remember, it's mostly when they marry, so they get different surnames.
Oh, yeah,
you can't go on that.
Yeah.
Yeah, you can't if it's a but I know definitely van Rooyen is a family name associated with that. And then in terms of the psychiatric patients, I think the moon, I also sometimes feel better when it's full moon. I don't know if that is something to be worried about, but there's definitely association with that. I don't think to screen all your psychiatry patients, but we do see a lot of unexpected psychiatric deaths. So I think it needs to come down to history and that's why psychiatry is so difficult, because it could be so many other things. So I don't know, Dr. Taban, I'm not sure about screening all your psych patients. Or if it's a known psychiatric patient, probably not. But if it's somebody that is the younger patients, maybe. But I'm not sure.
Yeah.
Yeah, I mean, we see so many patients with fibromyalgia, and we don't have a cause for it. Do you think be beneficial?
I don't think so. No, I've got a lot of. I'm not sure. I don't think so. Fibromyalgia, I feel is in an acute flare. I don't think it's going to be that chronic pressure point with porphyria. I don't think an acute flare will present like that. I think it won't be cost effective to screen the fibromyalgia patients, if I have to be honest with you. I don't think muscle pain is sort of very high up on the symptoms that I would associate with porphyria.
I think fibromyalgia perhaps is a condition that probably the name is just come out of really because we don't know what caused it.
Yeah.
And I think
Yeah.
I don't know. I think for people with severe disease, maybe skin or whatever, perhaps it was just urine. For me, I think it's because we don't know the diagnosis really, and most of the physicians shy away from fibromyalgia. When you hear fibromyalgia, you just want to walk away. But sometimes, such as like we had a patient with Guillain-Barré, that was, when we screened, then pick it up, that was the case. And of course, we have to order the treatment, and she recovered very well. So for me, is that I think there's no substitute for thinking. You have to think about it and try to see whether it actually is to exclude.
Yeah.
So I just have a question. So if you just do a screen, which is basically a urine, and that is negative, basically excludes it. So if a patient doesn't have any symptoms, can they still develop symptoms and then become positive, or?
Yes, because of the cyclical nature of the disease, it's all about trying to catch the bullet train. When it's coming past, you need to, when the symptoms are there, that's when I would do a screen. So if the screen is negative, for the PB, so if the PBG is negative, that's sort of the entry level, the entry level test that we do, the PBG, just so that we know we don't have to order heme arginate. But the total porphyrins are mostly elevated, and the total urine porphyrins is sort of is part of our screening test. And if the total porphyrins are positive, we would always write there, we suggest that you do a study. So if you only do a screen on this patient and their total porphs and their PBG are negative, I would not pursue the diagnosis any further unless they present at a later stage with symptoms. Then you can even tell the patient, if you're feeling like this, please collect urine, cover it with foil, please collect stool, cover it with foil, and come to casualty, just so that you can catch that bullet train when it is going past the station. But if the screen is negative, I would not pursue it in the absence of symptoms, doctor.
I think perhaps in the future, what we need to do is actually maybe create a patient education channel about all these conditions that we've been presenting to, so that because sometimes I think patients also can guide physicians based on their symptoms, because instead of them Googling for something that is really not factual. So perhaps maybe in the next year or so, we could actually make sure whenever we do presentation, we can have a small kind of patient ongoing education, like small than 5 minutes program for. I think that would probably help because at the end of the day, it's not the plan. Anybody online? Questions? Dr. Okoli, you are in Highfield Medical Clinic. Have you encountered any patient with porphyria?
Good morning. I have Doc. There's a patient that was already diagnosed who came in thinking she was in a flare, but it turned out she wasn't because we sent her the urine on that particular situation. Yeah. So once in a while we see them, but mostly those who are already diagnosed.
Yeah, but at least now you have something to learn and lean to. And I think what will happen, that obviously I hope Dr. Rossouw, you can ask you your number for obviously for things out there who are struggling, and then perhaps they could actually give you a call on something, and you can adjust how to actually diagnose. Because for us, I think sharing knowledge is key.
Definitely.
Thank you very much for the presentation. As Dr. Taban said, it is one of those topics that you might look at and go, oh gosh, this is so complex. Let's get over it. I'm glad you've given us a good presentation on this. Thank you so much.
Thank you. Thanks.
Yeah. So maybe next year we could probably get some cases that we have seen. I think we have seen one. Then maybe next we can case interaction, see how the presentation.
So I've actually removed the cases from the presentation because I have a few and they're so interesting and the histories are beautiful. So I've removed it from the presentation just in the interest of time. But there's just some really very interesting cases that we've seen. Yeah.
Love to hear them.
I think your next presentation should be about case discussion. You quiz us and then see how much we learn.
Nice. I love a good quiz. So no, definitely. Yeah.
Otherwise, thank you guys.
Thank you very much.
And we appreciate it. I think you can come join us now. We want to see you.
Yeah, no, I'll see you.